All right, everyone, welcome to Pharmacology Grand Rounds. Today, we are going to get really practical. We're diving into a topic you are absolutely going to see day in and day out on your clinical rotations: insomnia, especially in our older patients. We're going to focus on how to use medications safely and effectively so you're ready to make good decisions from day one.
And to do that, we're throwing the textbook out the window for a bit. Instead, we're going to walk through a real case, a patient of mine I've been working with for the last few months. I find this is the best way to really connect the dots between pharmacology theory and what you'll actually be doing on the wards. So let's get started.
So I'd like you to meet Amy. She's 66, a retired school teacher, and she's been battling chronic insomnia for the better part of a decade. And let me tell you, this isn't just some minor inconvenience for her. It's completely eroding her quality of life, her mood, her ability to just enjoy her retirement. Okay, let's build the clinical picture here. First, her sleep pattern. This is what we call a classic mixed insomnia. She has trouble on both ends. It takes her an hour or two just to fall asleep, she wakes up multiple times a night, and then that dreaded 4:30 a.m. wake-up call with no hope of getting back to sleep. All told, she's getting maybe 4-5 hours a night. Next, her medical history. Hypertension, osteoarthritis, GERD, pretty typical stuff. And finally, and this is where you come in, her medications. She's been using zolpidem on and off, and sometimes grabs over-the-counter diphenhydramine.
Now, before we treat anything, we've got to be sure about the diagnosis, right? So we did our due diligence. Her history didn't really point towards things like sleep apnea or restless leg syndrome, so we were able to rule those out. That let us confidently rule in a diagnosis of chronic insomnia disorder since she ticks all the boxes you see listed on the right.
So, what's our first move? I'll give you a hint. It's not reaching for the prescription pad. With insomnia, there's a really clear, evidence-based hierarchy of care, and following this structure, well, that's what separates thoughtful clinicians from just script writers.
And here it is. This pyramid shows you the way. The foundation, the absolute first thing we do, is Level 1 Cognitive Behavioral Therapy for Insomnia, or CBTI. You need to know this. It is the gold standard of care. It's strongly recommended for all adults, but especially older adults, because it works, the effects are long-lasting, and it's incredibly safe. But that brings us to the core of our discussion today. Amy did several months of CBTI, and she got better, but it just wasn't enough. She was still struggling. This is the exact clinical crossroads you're going to find yourself at, deciding if, when, and most importantly, how you're going to add a medication to her plan. Now, before we even talk about what to add, we have to talk about what to stop. Our number one guiding principle in medicine, and especially in pharmacology, is first, do no harm. For our geriatric patients, this means you have to get comfortable with tools like the Beers criteria and be really proactive about deprescribing, that is, taking away inappropriate medication. So let's look at what Amy's been taking. First, the benzodiazepine receptor agonists, or BZRAs. That's her zolpidem. And second, over-the-counter antihistamines like diphenhydramine. Look at the Beers criteria from the American Geriatric Society. Both of these drug classes have a big, bold, flashing avoid recommendation. Why? Because the risks, falls, delirium, cognitive problems, even strange sleep behaviors, they just dramatically outweigh any small benefit in this age group.
I really want to hammer this point home because patients always think, oh, it's over the counter, it must be harmless. It is not. The heavy anticholinergic burden from drugs like diphenhydramine can cause confusion, urinary retention, and what's really scary is that the more you use them, the higher the associated risk of dementia. Bottom line, these are contraindicated for chronic use in older adults, period.
And remember, none of this happens in a vacuum. It's never you just telling the patient what to do. It's a conversation. With Amy, we sat down and had a real discussion about all of this, the risks, the benefits, what she was hoping for. That's called shared decision-making, and it is essential.
Okay, so we've done the deprescribing, we've stopped the harmful medications, so now what? What are these safer, evidence-based tools in our pharmacology toolbox for a patient like Amy?
Our first choice option is a newer class of drugs called dual orexin receptor antagonists. We just call them DORAs. Now these are cool. Unlike the old drugs that just carpet bomb the brain with sedation, DORAs have a much more elegant mechanism. They work by blocking a neurotransmitter called orexin, which is basically the brain's main on switch. So instead of forcing sleep, they turn down the wake signal.
So for Amy, this is a fantastic option. DORAs help with both falling asleep and staying asleep, which is perfect for her mixed insomnia. And crucially for an older patient, they have a much cleaner safety profile when it comes to thinking and balance. The main downsides? Well, they can be pricey,
And we do have to watch out for a little bit of next-day grogginess.
But let's get even more specific. Think about Amy's chief complaint. One of the things that bothers her the most is that 4:30 a.m. wake-up. She just can't stay asleep. So that begs the question, is there a medication that's especially good for sleep maintenance?
And that question leads us right to our second preferred option, low-dose doxepin. Now, this is an old tricyclic antidepressant, but here's the key. At a very low dose, it basically acts as a super-selective H1 histamine receptor blocker. And that specific mechanism is fantastic for helping people stay asleep all the way through the night.
I cannot stress this enough. With doxepin, the dose is everything. At the tiny 3 to 6 milligram dose we use for insomnia, it's safe, it's targeted, and it doesn't have those nasty anticholinergic side effects. At the high doses used for depression, over 100 milligrams, it's like a completely different, much riskier drug. You have to remember that distinction. It's critical.
Okay, let's wrap this up. I want to boil down all of this complex pharmacology into a few key principles, things you can actually remember and take with you on your very first day of your clerkships.
Think of this slide as your clinical cheat sheet. You can see it all laid out here. Our preferred options, the DORAs and low-dose doxepin, have a caution or safe status on the Beers list. Compare that to the avoid status for the BZRAs and antihistamines. This is the kind of mental framework you should have every time you think about prescribing a sleep aid for an older adult.
So if you forget everything else, please remember these 4 principles. 1. CBTI is always where you start. It's the foundation. 2. First, do no harm. That means checking the Beers list and getting rid of bad meds. 3. Target the specific symptom. Is the problem getting to sleep or staying asleep? And 4. Individualized care. You're treating Amy, the retired school teacher, not just a complaint of insomnia.
So I'll leave you with this final thought. As you get ready to hit the wards, think about Amy's story. How are you going to use this kind of case-based thinking to go beyond just memorizing a list of drug names and really become a thoughtful, safe, and effective prescriber? Because at the end of the day, that's the goal. Thank you.